So in the previous class we had discussed about renal stones. What are the other types of renal stones and the treatment and management for different types of renal stones, and based on the size of renal stones also. Now we are starting with infections of kidney and ureter. Mainly in your curriculum they have mentioned perinephric abscess, but there are various other infections which in turn will lead to abscess formation. So we need to know about the infections of kidney and ureter before knowing about perinephric abscesses. So we'll start with infections of kidney and ureter today. So there is a similar analogy where they have correlated these infections with infection of gallbladder, common bile duct, so and so. Okay, so emphysematous cholecystitis is an infection of gallbladder where the most common organism involved is Clostridium perfringens and most common aerobic organism is E. coli. Similarly, there is emphysematous pyelonephritis, and here the organism involved most commonly is E. coli. Similarly, there is xanthogranulomatous pyelonephritis, where the most common organism is Proteus, that is, yesterday we had studied related to triple phosphate calculi or staghorn calculi. So, similarly, there is an infection of gallbladder called as xanthogranulomatous cholecystitis, which is a non-infectious condition. Okay, this is just inflammation, non-infectious, but this is an infection. So it's just an analogy, similarities between gallbladder infection and kidney and ureter infection. So starting with emphysematous pyelonephritis. So this emphysematous pyelonephritis is characterized by presence of a ring of air around the kidney, that is in the perinephric region or within the kidney. What happens here? Most common organism is E. coli or Klebsiella. Okay, most commonly seen in immunocompromised states like diabetes and also seen in case of females. So emphysema ಅಂದ್ರೆ ಏನು ನಮಗೆ ಗೊತ್ತು, like air is trapped within it, or basically related to lungs. If we have to talk about emphysema, there are dilated alveoli, right? Like initially this will be one alveoli, this will be other alveoli like this, but in emphysema all these alveoli will rupture and ultimately lead to a formation of a big air sac, right? So similarly here it is called as emphysematous pyelonephritis because here ring of air around the kidney. So if this is a kidney, there is a formation of a ring of air around the kidney and hence the name emphysematous. Pyelonephritis, nephritis we can say. Nephritis andreno, nephron means basically is a structural and functional unit of kidney. So nephronitis, inflammation of kidney. And pyelo means pus forming or maybe pelvis. So you can derive the definition from the name. So basically infection of the kidney or inflammation of the kidney where there is formation of ring of air around the kidney, and it is most common organism being E. coli and then followed by Klebsiella. Okay, what will be the clinical features? Just like infection is there, there will be fever and then flank pain will be there because of ongoing inflammation. Along with this, there will be vomiting. Okay, mortality rate being 19 to 43%. Okay, so how will we diagnose this condition? On X-ray, there will be presence of air in relation to the kidney. Based on this, we can say, okay, this is an emphysematous pyelonephritis. Other than that, investigation of choice, CT scan. Okay, how will we treat this? So since it is caused by a bacteria like E. coli, antibiotics is the treatment, and IV antibiotics is needed because it is a high grade infection. Other than that, again, vomiting adu idu idre, we will have to manage fluid by giving fluid so that electrolyte imbalance ಎಲ್ಲ ಏನೂ ಆಗಬಾರ್ದು. Along with that, he won't be taking food because of vomiting, so blood glucose, ಅದ್ರ ಜೊತೆಗೆ ಡಯಾಬಿಟಿಕ್ ಏನಾದರೂ ಇದ್ದರೆ again we will have to treat this diabetes and control blood glucose. Okay, because this is usually seen in case of immunocompromised states like diabetes. Okay, after that, if there is pus formation like pyogenic ಏನಾದರೂ ಇದ್ದರೆ or evidence of infection ಪಕ್ಕ ಇತ್ತು ಅಂದರೆ then we should drain it. So drain ಹೆಂಗೆ? surgically. Okay, other than that, nephrectomy is done to save the patient if there is loss of function of the kidney. Okay, so basically if we know the clinical etiology, we can aram se say the treatment. So here what is happening? Because of E. coli or Klebsiella, there is inflammation of the kidney first or infection first. Infection in turn will lead to pyelonephritis, that is inflammation of the kidney. So because of this pyelonephritis, there is accumulation of ring of air around it, and hence it is named as emphysematous pyelonephritis. So ultimately what we have to do, we will have to treat this E. coli, and along with that, because of this emphysematous pyelonephritis, there can be fever, vomiting. Because of this vomiting, electrolyte imbalance can be there, and fever. So we will have to treat the clinical symptoms as well as the cause. So for vomiting and electrolyte imbalance, we'll go for resuscitation. For fever, paracetamol you can give, or IV antibiotics will also treat the cause. Along with that, IV antibiotics. If this pyelonephritis has caused an abscess or pus, then we will have to treat this by draining the pus. If this pyelonephritis causes a long-term sequelae like renal failure or suppose loss of function of kidney, then we will have to remove that part in order to save the remaining part of the kidney. So we will do a nephrectomy. So this is entire outline of any kidney infection per se. This regarding emphysematous pyelonephritis I have taught you. Okay. Similarly, next, what is xanthogranulomatous pyelonephritis? So this is a chronic bacterial infection, and the most common organism is Proteus. So this, hence Proteus, as we all know, it is associated with staghorn calculi. Similarly, this xanthogranulomatous pyelonephritis is associated with struvite stone, which causes obstructed and hydronephrotic kidney. Okay, what is the pathology here? There is presence of xanthoma cells in the renal parenchyma. Because of this reason, xanthoma cells irodrinda, this is named as xanthogranulomatous pyelonephritis. Okay, so this is foamy lipid laden histocytes, and this mimics clear cell variant of RCC. Basically, if this is a cell, one endal nucleus irutte, rest part will be lipid. So when we visualize this under microscope, it appears like there is no nucleoli and the cell is clear. Because of this reason, it is known to resemble clear cell variant of RCC. Okay, so these cells are called as xanthoma cells, and these, hence the name xanthogranulomatous pyelonephritis. So what will be the clinical feature? Again, in any case of infection, there will be flank pain, fever with chills and rigor will be there, bacteriuria will be there. Along with that, there can be appreciation of a mass in the flank, which was not there in case of emphysematous pyelonephritis. Okay, investigation being contrast enhanced CT. Here, X-ray doesn't have any role because there is no air here. Okay, after this, what will be the treatment? Initially, partial nephrectomy, because once the kidney has been damaged or it has reached a certain level, we can't do anything. We will have to remove a part of kidney in order to save the rest of the part. If this is not possible, partial nephrectomy is not possible, then we will have to go for total nephrectomy. Okay. So now we will have to know the difference between perinephric abscess and pyonephrosis. Perinephric andre collection of pus around the kidney. Okay. But pyonephrosis andre pus is collected inside the kidney, or kidney behaves like a bag of pus. Okay. So if this is a kidney, if the fat is around the kidney, this is perinephric abscess. If the pus is formed within the kidneys, then this is pyonephrosis. So this is perinephric abscess and this is pyonephrosis. And now we are going to discuss first about pyonephrosis, and then we will in detail talk about perinephric abscess. Okay, so related to two infections we have discussed today, one being emphysematous, other one being xanthogranulomatous. Major difference is the organism causing it, and name has been derived based on the pathology. Okay, so xanthogranulomatous alli xanthoma cells irutte, which is mainly because of the organism Proteus, rest being the same. Okay, and here treatment is partial nephrectomy or total nephrectomy. After this, the third disease we are discussing today is the pyonephrosis, in which pus is within the kidney and kidney acts as a bag of pus. Okay, this is seen in case of chronic obstruction like hydronephrosis. Illénagutte, destruction of the renal parenchyma occurs, and because of that reason there will be pus collection. So imagine there is an obstruction in the outlet. Okay, so because of some staghorn calculi or because of distal ureteral obstruction, somehow there is accumulation, there is obstruction here. Because of this reason, whatever the urine or whatever the fluid was getting accumulated, so it is stopped here, and this will reflux now. Because of that reason, whatever the fluid has to go out from here, that is not going out, so everything is getting accumulated here. That leads to enlargement of the kidney. This enlargement is nothing but hydronephrosis. So because of this enlargement, there will be stretching of the capsule and parenchyma, everything. So because of this excessive stress over the renal parenchyma, there will be damage to this or destruction of this renal parenchyma. Because of this destruction, what happens? All the cells and everything will be accumulated here, and that will serve as a site for infection, and that will lead to formation of pus, in turn leading to pyonephrosis. Okay, so major event which is necessary or which is leading to pyonephrosis is obstruction. It can be at any level. It can be at upper 1/3 of ureter or lower 1/3 of ureter or at the renal pelvis itself. So wherever the obstruction is there, this will be the sequel that will follow. And the most common cause being renal stone. So what will be the clinical feature? First, there will be fever. Like once the infection or once the pus collection sets in, there will be fever. After that, there will be mass in the loin because kidney is enlarged now, and we will be able to feel the kidneys. So because of that, we will think, okay, this is a mass. And then anemia. Okay, because it is a chronic disease, and in chronic diseases like erythropoietin production happens in kidneys, so this might be hampered, and because of that reason, again, anemia of chronic disease will set in. Okay, so these are the clinical features. How can we diagnose? Just like we all know, water is there in the kidney, so any fluid we will be best appreciated by USG, so we'll go for USG. That is the diagnosis. After that, after diagnosing, how will we treat? Drainage, and for infection we'll give antibiotics. So how will we drain? We can do percutaneous nephrostomy, okay, in older and diabetics, etc. If there is non-functioning kidney, then we will have to remove that part of the kidney, that is nephrectomy. Okay, so this was about pyonephrosis. Okay, now coming to the next etiology or next disease, that is perinephric abscess. So just like I have explained before, perinephric abscess is a collection of pus around the kidney. Okay, so this can spread by two routes: cortical extension and hematogenous spread. Okay, urine culture is positive in 1 to 1/3 of the cases, blood culture is positive in 50% of the cases, and most common organism is E. coli first and then Proteus. So basically whatever this pus has been formed, this can spread by two routes. That is, one is by cortical extension, other one into the blood, and then from blood to entire body. Okay, in that cases, so this might come out through urine also, hence urine culture might be positive in 1/3 of the cases. If it comes into blood through hematogenous route, then blood culture will be positive in 50% of the cases. Okay, what will be the clinical feature? Again, there will be pain because there is an abscess, so ongoing inflammation will be there, and pain and tenderness will be there. Along with that, since there is an infection, fever will be there. How will we diagnose this? Again, it is an abscess, so fluid will be there. We can go for USG, or in order to know the extent of the abscess extension, we can go for CT scan. So how will we manage? Abscess is drain ಮಾಡಬೇಕು, that is percutaneous drainage, and to treat the infection we'll go for IV antibiotics. If the patient is not responding for these IV antibiotics and percutaneous drainage, then we will have to go for open drainage, and then if the kidney is not functioning, nephrectomy. Okay, yeah, so these were the four main infections which we discussed till now: emphysematous pyelonephritis, xanthogranulomatous pyelonephritis, pyonephrosis, and perinephric abscess. Ultimately, for everything, treatment will become IV antibiotic, abscess ಆಗಿದ್ರೆ drain ಮಾಡಿ, and then if not, nephrectomy. Okay, so ultimately istane treatment. We will have to identify the cause for that. Okay, after this we are coming to main pathology, that is genitourinary TB. So this will include entire the genital and the urinary part of anatomy where TB is affecting us. Okay, so the most common organism, as we all know, is Mycobacterium tuberculosis. It is most commonly seen in males in 20 to 40 years of age group. So most common route of spread in case of genitourinary TB, it is hematogenous. Okay, not contact or not by aerosol route. Okay, so genitourinary TB is known to spread through hematogenous route. Primary organ, again lungs. So basically a person gets infected with TB, and this TB will start spreading throughout the body through hematogenous route, and this will reach the genitourinary tract, causing genitourinary TB. ಓಕೆ, ಸೊ ಫಸ್ಟ್ ಲಂಗ್ಸ್ಗೆ ಇನ್ಫೆಕ್ಟ್ ಆಗಿರುತ್ತೆ, ಅದಾದಮೇಲೆ ಹೆಮೆಟೋಜಿನಸ್ ರೂಟ್ ಮೂಲಕ ಜನೈಟೋಯೂರಿನರಿ ಟಿ ಬಿ ಡೆವಲಪ್ ಆಗುತ್ತೆ. ಓಕೆ, ಪ್ರೈಮರಿ ಆರ್ಗನ್ಸ್ ಯಾವ್ದು ಇನ್ವಾಲ್ವ್ ಆಗುತ್ತೆ ಅಂದರೆ ಯೂಶಲಿ ಜನೈಟೋಯೂರಿನರಿ ಟಿ ಬಿಯಲ್ಲಿ ಕಿಡ್ನಿ ಆ್ಯಂಡ್ ಪ್ರೋಸ್ಟೇಟ್ ಆರ್ ದ ಮೋಸ್ಟ್ ಕಾಮನ್ ಒನ್ಸ್ ಅಫೆಕ್ಟೆಡ್. ಸೆಕೆಂಡರಿಲಿ by ascent of infection or descent of infection, from kidney it can descend to ureter and urinary bladder, or from prostate it can ascend to vas deferens. Okay, so first ivered infect ಆಗುತ್ತೆ, ಅದಾದಮೇಲೆ these will be the site or foci for infection, and then this will spread downwards and this will spread upwards, involving the entire genitourinary tract. Okay, so next, what is the pathophysiology here? Just like I have explained before, bacteria which is there already in the lungs, from the hematogenous route of spread, this will reach the kidneys, and there they will get lodged into periglomerular capillaries. Okay, if the person has good immunity, he won't get genitourinary TB, infection will be cleared. If there is bad immunity, then whatever these organisms or bacteria, that is Mycobacterium tuberculosis, which is lodged in the periglomerular capillaries, they will get activated. Okay, and they will lead to formation of just like the TB formation, like granulomas, caseous necrosis ಎಲ್ಲ ಆಗುತ್ತಲ್ಲ, granuloma formation ಆಗುತ್ತೆ ಇಲ್ಲಿ ಕಾರ್ಟೆಕ್ಸ್ ಅಲ್ಲಿ. From that there will be formation of, again granuloma ಆದ್ಮೇಲೆ there will be abscess, and this is called as tubercular abscess because it is caused by tuberculosis. After this there will be rupture of this abscess into the pelvis and calyxial system. So this in turn will be excreted through urine, that is called as sterile pyuria. ಓಕೆ, ಸ್ಟೆರೈಲ್ ಪೈಯೂರಿಯಾ ಅಂತ ಯಾಕೆ ಕರಿತೀವಿ ಅಂದರೆ ಯೂರಿನ್ ರೊಟೀನ್ ಆ್ಯಂಡ್ ಮೈಕ್ರೋಸ್ಕೋಪಿಯಲ್ಲಿ ವಿ ಕ್ಯಾನ್ ಸಿ ಓನ್ಲಿ ಪಸ್ ಸೆಲ್ಸ್, ಬಟ್ ಕಲ್ಚರ್ ಆ್ಯಂಡ್ ಸೆನ್ಸಿಟಿವಿಟಿ ಮಾಡಿದರೆ ದರ್ ವಿಲ್ ನಾಟ್ ಬಿ ಎವಿಡೆನ್ಸ್ ಆಫ್ ಎನಿ ಗ್ರೋತ್. ಸೊ ಯಾವುದು ಬ್ಯಾಕ್ಟೀರಿಯಾ ಇಲ್ಲ ಬಟ್ ಪಸ್ ಸೆಲ್ ಬೆಳೀತಿದೆ, ಸೊ ಅದಕ್ಕೆ ಏನು ಹೆಸರಿಡ್ತಾರೆ ಇದಕ್ಕೆ ಅಂದರೆ ಇಟ್ ಈಸ್ ಸ್ಟೆರೈಲ್, ದೆರ್ ಈಸ್ ನೋ ಗ್ರೋತ್ ಆಫ್ ಎನಿ ಆರ್ಗ್ಯಾನಿಸಮ್, ಬಟ್ ಪಸ್ ಇದೆ ಯೂರಿನಲ್ಲಿ, ಸೊ ಪೈಯೂರಿಯಾ. ಓಕೆ, ಹೆನ್ಸ್ ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಟು ನೋಟ್ ದಟ್ ಸ್ಟೆರೈಲ್ ಪೈಯೂರಿಯಾ ಇಸ್ ಸೀನ್ ಇನ್ ಕೇಸ್ ಆಫ್ MTB, ದಟ್ ಈಸ್ ಜನೈಟೋಯೂರಿನರಿ TB. ಮೋಸ್ಟ್ ಕಾಮನ್ ಅರ್ಲಿಯೆಸ್ಟ್ ಸಿಂಪ್ಟಮ್ ಏನಿರುತ್ತೆ ಅಂದರೆ ಇನ್ಕ್ರೀಸ್ಡ್ ಫ್ರೀಕ್ವೆನ್ಸಿ ಆಫ್ ಮಿಕ್ಚುರೇಷನ್. ಓಕೆ, ಆಗಲೆಲ್ಲ ಹೋಗಬೇಕಂತ ಅನ್ನಿಸ್ತಿರುತ್ತೆ ಬಿಕಾಸ್ ಆಫ್ ಇನ್ಫೆಕ್ಷನ್, ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ಸ್ಟೆರೈಲ್ ಪೈಯೂರಿಯಾ. ಓಕೆ, ಸೊ ನಾವು ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಫ್ರಮ್ ಕಿಡ್ನಿ ಆ್ಯಂಡ್ ಯುರೇಟರ್. ಇನ್ ಕಿಡ್ನಿ ಆ್ಯಂಡ್ ಯುರೇಟರ್ ದರ್ ವಿಲ್ ಬಿ ಕ್ಯಾಲಿಸಿಯಲ್ ಸ್ಟೀನೋಸಿಸ್ ಆರ್ ಸ್ಟೀನೋಸಿಸ್ ಅಟ್ ಪೆಲ್ವಿಯುರೆಟ್ರಿಕ್ ಜಂಕ್ಷನ್. ಸೊ ದಿಸ್ ಇನ್ ಟರ್ನ್ ವಿಲ್ ಲೀಡ್ ಟು, ಬೇಸಿಕಲಿ ಸ್ಟೀನೋಸಿಸ್ ಅಂದರೆ ಏನು, ಸಣ್ಣದಾಗುತ್ತೆ ಪ್ಯಾಸೇಜು. ಸೊ ಸ್ಟೀನೋಸಿಸ್ ಆಯ್ತಂದರೆ ಅಗೇನ್ ದಿಸ್ ಸರ್ವ್ಸ್ as a partial obstruction. Partial obstruction ಆಯ್ತಂದ್ರೆ ರಿಫ್ಲಕ್ಸ್ ಆಗುತ್ತೆ, that will lead to hydronephrosis, and again that will serve as a foci for infection, it will lead to pyonephrosis. This in turn can cause perinephric abscess, and abscess ಆಗಿ ನೆಕ್ಸ್ಟ್ ಏನಾಗುತ್ತೆ, ಗ್ರಾನ್ಯುಲೋಮಾ ಫಾರ್ಮೇಷನ್ ಆಗುತ್ತೆ, it will lead to caseous necrosis, which is a hallmark of TB. After this the kidney will be filled with cheesy material because of caseous necrosis, and this kidney filled with cheesy material is called as putty kidney. And after this cheesy material is filled, it will start undergoing calcification, and this calcified kidney is known as cement kidney. Okay, and this cement kidney will become non-functioning calcified kidney, which is nothing but nephrectomy. Hence it is called as autonephrectomy. So kidney idrunu ಏನು ಯೂಸ್ ಇಲ್ಲ, hence it is called as autonephrectomy. Okay. So autonephrectomy is seen in case of genitourinary TB. Similarly, autosplenectomy is seen in case of sickle cell disease. Okay. So bladder ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ TB ಇಂದಾಗಿ? In urinary bladder, infection moves from ureter into the bladder. So this we saw. Okay. It is descending infection. ಕಿಡ್ನಿಗೆ ಬಂತು, ಕಿಡ್ನಿಯಿಂದ ಯುರೇಟರ್ಗೆ ಬಂದಿದೆ, ಯುರೇಟರಿಂದ ಇವಾಗ ಬ್ಲ್ಯಾಡರಿಗೆ ಬರ್ತಿದೆ. ಸೊ ಇನ್ಫೆಕ್ಷನ್ ಯುರೇಟರಿಂದ ಬ್ಲ್ಯಾಡರಿಗೆ ಬಂದರೆ ಏನಾಗುತ್ತೆ? Pallor will be noticed around the ureteric orifice in the bladder, which is the initial sign visualized during cystoscopy in TB is this one, pallor around the ureteric orifice. Suppose ನಮಗಿನ್ನೂ ಡಯಾಗ್ನೋಸಿಸ್ ಗೊತ್ತಿಲ್ಲ, ಇವಾಗ ನಾವು ಏನೋ ರೆಟ್ರೋಗ್ರೇಡ್ಲಿ ಹೋಗ್ತಿದ್ದೀವಿ, ಪೇಷಂಟಿಗೆ ಜನಟೋಯೂರಿನರಿ TB ಆಗಿದೆ ಅಂದರೆ ಬ್ಲ್ಯಾಡರಲ್ಲಿ ಏನು ಕಾಣಿಸುತ್ತೆ ಅಂತ. ಬಟ್ ಇನ್ ದ ರಿಯಲ್ ಲೈಫ್ ಸಿನಾರಿಯೋ ಇಟ್ ವಿಲ್ ಬಿ ಆಪೋಸಿಟ್. ಪೇಷಂಟ್ ವಿಲ್ ಕಮ್ ಟು ಅಸ್ ಸೇಯಿಂಗ್ ಐ ಹ್ಯಾವ್ ಇನ್ಕ್ರೀಸ್ಡ್ ಫ್ರೀಕ್ವೆನ್ಸಿ ಆಫ್ ಮಿಕ್ಚುರೇಷನ್, ಓಕೆ, ಆ್ಯಂಡ್ ಫ್ಲ್ಯಾಂಕ್ ಪೇನ್, fever, some 3 or 4 symptoms like this. Now we will have to evaluate. What we will do, we will think, okay, there might be cystitis, like bladder infection ಆಗಿರ್ಬೋದು. We will do a cystoscopy and we will see ಅಂತ ಹೇಳಿ now we will order a cystoscopy. On cystoscopy, if we are able to visualize pallor around the ureteric orifice, ಇವಾಗ ಇದು ಯೂರಿನರಿ ಬ್ಲ್ಯಾಡರ್ ಅಂದರೆ ಯುರೇಟರ್ ಬಂದು ಇಲ್ಲಿಂದ ಹಿಂಗೆ ಓಪನ್ ಆಗಿರುತ್ತೆ. If we are able to see pallor around these 2 ureteral orifices, then it is a sign of genitourinary TB in which bladder is involved. Okay, so this is the initial sign. If we do cystoscopy and we are able to visualize pallor under ureteric orifice, then it is the initial sign that it is genitourinary TB. So if the patient has not come to us in the early stage and it has undergone chronic inflammation, then chronic inflammation will form tubercles in the bladder, which will ultimately lead to fibrosis, and the bladder will become small and contracted, and this bladder, which is small, contracted, with highly reduced capacity, this bladder is called as thimble bladder. Okay, so there are various terminologies which have been introduced in genitourinary TB. These are important. Related to kidney, we studied putty kidney and cement kidney. Related to bladder, we are studying thimble bladder. Okay, in advanced cases of TB, when there is contracted bladder, it gives golf hole ureteric orifice. Okay. So next, prostate affect ಆದರೆ ಏನಾಗುತ್ತೆ? Prostate becomes calcified. It becomes hard and nodular. But one thing we have to note here is testis is spared in case of genitourinary TB. Testis is not affected. ಓಕೆ, ಸೊ ಈ ಪ್ರೋಸ್ಟೇಟ್ ಇಂದ ಏನಾಗುತ್ತೆ? ಇಟ್ ವಿಲ್ ಅಸೆಂಡ್ ಅಪ್. ಸೊ ಅಸೆಂಡ್ ಅಪ್ ಅಂದರೆ ಪ್ರೋಸ್ಟೇಟ್ ಇಂದ ನೆಕ್ಸ್ಟ್ ಎಲ್ಲಿಗೆ ಬರುತ್ತೆ? ಇಟ್ ವಿಲ್ ಕಮ್ ಟು ವ್ಯಾಸ್ ಡಿಫರೆನ್ಸ್. ಸೊ ವ್ಯಾಸ್ ಡಿಫರೆನ್ಸ್ ಇಂದ ಅಫೆಕ್ಟ್ ಆದರೆ ದಿಸ್ ವ್ಯಾಸ್ ಡಿಫರೆನ್ಸ್ ವಿಲ್ ಅಪಿಯರ್ ಇನ್ ದ ಫಾರ್ಮ್ ಆಫ್ beaded. Again, there will be multiple strictures of vas deferens. So this will lead to beaded appearance of vas deferens with multiple discharging sinuses into the scrotum. Okay. So this is the feature if prostate is affected. Prostate in the, it will ascend up to involve vas deferens, and then there will be multiple discharging sinuses involving scrotum. Okay. So these were the clinical features. So based on this, whatever the site is affected, based on that there can be clinical features. Okay, after this, how will we investigate? Again, urine routine and microscopy ಮಾಡ್ತೀವಿ. ಅದರಲ್ಲಿ ಪಸ್ ಸೆಲ್ಸ್ ಗೊತ್ತಾಗುತ್ತೆ. ಓಕೆ, ದೇರ್ ಈಸ್ ಇನ್ಫೆಕ್ಷನ್, ಅದು ಗೊತ್ತಾಯಿತು. ಬಟ್ ಯೂರಿನ್ ಕಲ್ಚರ್ ಆ್ಯಂಡ್ ಸೆನ್ಸಿಟಿವ್ ಮಾಡಿದಾಗ ದೇರ್ ಈಸ್ ನೋ ಗ್ರೋತ್ ವಿತಿನ್ 48 hours. Hence, that it is diagnosed as sterile pyuria, and sterile pyuria we know it is seen in case of genitourinary TB. So we can diagnose this based on that. Other than that, earliest sign of renal TB, if kidney is involved, then if we do IVP, intravenous pyelography, then moth eaten calyx ಥರ ಇರುತ್ತೆ. ಓಕೆ, moth eaten calyx ಅಂದ್ರೆ ಹಿಂಗೆ ಈ ಥರ ಲೈಕ್ ಸಮ್ ಯಾವುದೋ ಒಂದು ಹುಳು ತಿಂದಿದೆ ಕಿಡ್ನಿನ ಅನ್ನೋ ಥರ ಕಾಣಿಸ್ತಿರುತ್ತೆ ಕಿಡ್ನಿ. ಓಕೆನಾ? ಸೊ ದ್ಯಾಟ್ ಈಸ್ ಅರ್ಲಿಯೆಸ್ಟ್ ಸೈನ್. ಆ್ಯಂಡ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಆಫ್ ಚಾಯ್ಸ್ ಫಾರ್ ಡಯಾಗ್ನೋಸಿಸ್ ಆಫ್ ಅರ್ಲಿ ಸೈನ್ಸ್ ಈಸ್ ಅಗೇನ್ IVP. IVP ಮಾಡಿದಾಗ ಬೇರೆ ಏನೇನು ಚೇಂಜಸ್ ಇರುತ್ತೆ ಮಾತ್ ಇಟನ್ ಕ್ಯಾಲಿಕ್ಸ್ ಜೊತೆಗೆ ಬಿಟ್ಟರೆ ಅಂದರೆ ಕ್ಯಾಲಿಕ್ಸ್ ಬಿಕಮ್ಸ್ swollen and dilated, and that is called as calactasis. Ectasis ಅಂದರೆ ಬೇಸಿಕಲಿ ಡೈಲೇಷನ್ ಆಫ್ ಎನಿ ಡಕ್ಟ್, ಆ ಥರ. ಡಕ್ಟ್ ಎಕ್ಟೇಸಿಯಾ ಅಂದರೆ ಡಕ್ಟ್ ಹ್ಯಾಸ್ ಬಿಕಮ್ ಡೈಲೇಟೆಡ್ ಆ್ಯಂಡ್ swollen. Similarly, calyx has become ectatic, that is dilated. Okay, other than that, there can be a space occupying lesion or there can be ಪಾರ್ಷಲ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದ್ರಿಂದ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್ ಇರ್ಬೋದು. ಸೊ IVP ಮಾಡಿದಾಗ ಇದು ಯಾವುದೇ ಒಂದು ಫೀಚರ್ಸ್ ಕಾಣಿಸಿದ್ರು ಇಟ್ ಈಸ್ ಡಯಾಗ್ನೋಸ್ಟಿಕ್ ಆಫ್ genitourinary TB or renal TB. After that, investigation of choice for renal TB is contrast enhanced CT scan. We can know the extent of the disease. Okay. Other than that, retrograde pyelogram ಮಾಡಿದ್ರೆ ಏನಾಗುತ್ತೆ, pipe stem ureter. Basically, ureter ಅಲ್ಲಿ ಏನಾದರೂ ಆಗಿದ್ರೆ there will be medial deviation of the ureter and that is called as pipe stem ureter. Okay. So here in this diagram you can see pipe stem ureter ಸಣ್ಣದಾಗಿದೆ full. Okay. So actual treatment we will have to treat the TB first and then we will have to manage all this complication. Whatever genitourinary TB is there, that is a complication of TB. So for that reason we will have to treat the TB first and that is anti-tubercular drugs. Okay, HRZD 2 months ಆಮೇಲೆ HRZ 4 months. So same treatment, anti-tubercular treatment ಕೊಡಬೇಕು. For these complications we will have to manage these complications. Okay, complications ಏನೇನಾಗ್ಬೋದು, ಯೂರೆಟ್ರಿಕ್ ಸ್ಟ್ರಿಕ್ಚರ್ ಆಗ್ಬೋದು or dilation ಆಗ್ಬೋದು. Okay, for small contracted bladder ಗೆ we will have to, this is the treatment, so stricture of the ureter can happen and treatment is dilating the ureter. For small and contracted thimble bladder ಗೆ we will have to do augmentation enterocystoplasty. That is, we will have to get the tissue from somewhere else and do the augmentation of the small contracted bladder. Okay, ಎಂಟೆರೋ ಅಂದರೆ ಇಂಟೆಸ್ಟೈನ್, ಯೂಶಲಿ ಇಂಟೆಸ್ಟೈನಿಂದ ತೊಗೊಂಬಂದು ಒಂದಷ್ಟು ಟಿಶ್ಯೂನ ಬ್ಲ್ಯಾಡರ್ಗೆ ಹಾಕಿ they'll do enterocystoplasty. Okay, and then for non-functioning kidney, again just like all other conditions, it is nephrectomy. Okay, if there is non-dilatable stricture, so ureter stricture ಎಷ್ಟಾಗಿದೆ ಅಂದರೆ we are unable to dilate it and there is involvement of lower third of the ureter, then we will do a surgery called as Boary's operation. Boary's operation ಅಲ್ಲಿ ಏನು ಮಾಡ್ತೀವಿ, ಈ ಎಲ್ಲಿ ಯಾವ ಪಾರ್ಟ್ ಆಫ್ ಯುರೆಟರ್ ಹ್ಯಾಸ್ ಅಂಡರ್ಗಾನ್ ಸ್ಟ್ರಿಕ್ಚರ್ ಅದನ್ನು ಎಕ್ಸೈಸ್ ಮಾಡ್ತೀವಿ, ಆಯಿತಾ. ಆ್ಯಂಡ್ ದೆನ್ ವಿ ವಿಲ್ ರೈಸ್ ಅ ಫ್ಲ್ಯಾಪ್ ಫ್ರಮ್ ಬ್ಲ್ಯಾಡರ್. ಸೊ ಹಿಯರ್ ಯು ಕ್ಯಾನ್ ಸಿ ದೇ ಹ್ಯಾವ್ ಪುಟ್ ಅನ್ ಇನ್ಸಿಷನ್ ಓವರ್ ದ ಬ್ಲ್ಯಾಡರ್ ನೌ ಆ್ಯಂಡ್ ದೇ ಹ್ಯಾವ್ ರೈಸ್ಡ್ ದ ಫ್ಲ್ಯಾಪ್. ಓಕೆ, ರೈಸ್ ಮಾಡಿ ದೆನ್ ದೇ ವಿಲ್ ಸೂಚರ್ ಇಟ್. ಸೊ ಬೇಸಿಕಲಿ if this is ureter and this part has undergone stricture and here is the bladder. So ಇವಾಗ ಏನು ಮಾಡ್ತಾರೆ, they will excise this strictured part and then they will put an incision here and then raise a flap. ಇದನ್ನು ಮೇಲಕ್ಕೆ ಎತ್ತುತ್ತಾರೆ ಈ ಥರ. ಓಕೆ, ಸೊ ಇವಾಗ ಏನಾಗುತ್ತೆ, this is stricture part, bladder, this part of bladder is emptied and it is sutured here. Okay, so this becomes complete ureter now and this is called as Boary's operation, which is used in non-dilatable stricture of lower 1/3 of the ureter, because lower allidre matra we can raise the flap and easily connect it, illella agidre we can't, ಆಯ್ತಾ. Okay, so this was about genitourinary TB. So in genitourinary TB what all we studied andre related to introduction, then pathophysiology, ಆಮೇಲೆ ಎವ್ರಿ ಇಂಡಿವಿಜುವಲ್ ಆರ್ಗನ್ ಬಗ್ಗೆ ಓದಿದ್ವಿ. ಲೈಕ್ ಇಂಟ್ರೋ ಗೊತ್ತಾಯಿತು, ಇಟ್ ಈಸ್ ಮೋಸ್ಟ್ ಕಾಮನ್ ಬಿಕಾಸ್ ಆಫ್ MTB, ಮೈಕೋಬ್ಯಾಕ್ಟೀರಿಯಂ ಟ್ಯುಬರ್ಕ್ಯುಲೋಸಿಸ್. ಆಫ್ಟರ್ ದಟ್ ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ಇನ್ವಾಲ್ವ್ಡ್ ಆರ್ಗನ್ಸ್ ಆರ್ ಕಿಡ್ನಿ ಆ್ಯಂಡ್ ಪ್ರೋಸ್ಟೇಟ್. ಓಕೆ, ಕಿಡ್ನಿಯಲ್ಲಿ ಮೋಸ್ಟ್ ಕಾಮನ್ ಫೈಂಡಿಂಗ್ಸ್ ಏನೇನಿರುತ್ತೆ, ಪುಟ್ಟಿ ಕಿಡ್ನಿ ಆ್ಯಂಡ್ ಸಿಮೆಂಟ್ ಕಿಡ್ನಿ ನೆನ್ಪಿಟ್ಕೊಳ್ಳಿ ಸಾಕು. Okay, after that from the kidney the infection can descend and involve ureters. Ureter alli starting pallor around the ureter orifice adu bladder ge. Okay, ureter will undergo stricture ashte innella. Ureter orifice, this is in case of bladder, so ureter inda it can descend to bladder. After this again prostate involve ಆಗ್ಬೋದು. Prostate will become calcified, hard and nodular. After this, from here it can ascend to vas deferens. Vas deferens will become beaded. Okay, ಅದಾದಮೇಲೆ discharging sinuses create ಆಗುತ್ತೆ and this sinuses will drain into scrotum. What is the most important point? Testis is not involved. ಸೊ ಟ್ರೀಟ್ಮೆಂಟ್ ಏನು ಮಾಡಬೇಕು, ಫಸ್ಟ್ ಟಿ ಬಿ ಟ್ರೀಟ್ ಮಾಡಬೇಕು, ಆಮೇಲೆ ಇದರಿಂದ ಆಗೋ ಕಾಂಪ್ಲಿಕೇಶನ್ಸ್ನ ಮ್ಯಾನೇಜ್ ಮಾಡ್ಬೋದು. ಓಕೆ, ಸೊ ದಿಸ್ ವಾಸ್ ಅಬೌಟ್ genitourinary TB. ನೆಕ್ಸ್ಟ್ ಒನ್ ಬೀಯಿಂಗ್ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್. ಸೊ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್ ಇವಾಗ ಇದುವರೆಗೂ ಏನೇನು ಓದಿದ್ವಿ ಅವೆಲ್ಲ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಗುತ್ತೆ. ಎನಿ ಕೈಂಡ್ ಆಫ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ವಿಲ್ ಲೀಡ್ ಟು ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್. ಸೊ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಯಾವ್ಯಾವುದರಿಂದ ಆಗ್ಬೋದು, ಇನ್ಫೆಕ್ಷನ್ನಿಂದ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗ್ಬೋದು, ಸ್ಟೋನಿಂದ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗ್ಬೋದು. ಯಾ, ಸೊ ಮೈನ್ ಇವೆರಡು. ಓಕೆ, ಆ್ಯಂಡ್ ಸ್ಟ್ರಿಕ್ಚರ್. ಸೊ this is a aseptic dilatation of kidney, okay, which is caused by outflow obstruction of the urine, and this can be unilateral or bilateral. So causes of unilateral hydronephrosis ಏನು, bilateral hydronephrosis ಏನು, this they can ask. Okay, so unilateral ಅಂದರೆ ಒಂದೇ ಒಂದು ಸೈಡು. ಅದರಲ್ಲಿ ಯೂನಿಲ್ಯಾಟ್ರಲ್ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್ ಕಾಸಸ್ನ ಮತ್ತೆ 3 ಥರ ಡಿವೈಡ್ ಮಾಡ್ಬೋದು. ವಿ ಕ್ಯಾನ್ ಡಿವೈಡ್ ದೀಸ್ ಕಾಸಸ್ ಇಂಟು 3 ಟೈಪ್ಸ್: ಎಕ್ಸ್ಟ್ರಾಮ್ಯೂರಲ್, ಇಂಟ್ರಾಮ್ಯೂರಲ್ ಆರ್ ಇಂಟ್ರಾಲುಮಿನಲ್. ಓಕೆ, ಸೊ ಎಕ್ಸ್ಟ್ರಾಮ್ಯೂರಲ್ ಏನು, ಅಡ್ವಾನ್ಸ್ಡ್ ಮ್ಯಾಲಿಗ್ನೆನ್ಸೀಸ್ ಲೈಕ್ ಕೋಲೋರೆಕ್ಟಲ್ ಕ್ಯಾನ್ಸರ್, ಸಿಎ ಸರ್ವಿಕ್ಸ್, ಸಿಎ ಪ್ರೊಸ್ಟೇಟ್ ಇವೆಲ್ಲ ಕಿಡ್ನಿಗೆ ಸ್ಪ್ರೆಡ್ ಆಗುತ್ತೆ ಅಂತ ಓದಿದ್ವಲ್ಲ. ಸೊ ದೇರ್ ಇಟ್ ಇನ್ವಾಲ್ವ್ಸ್ ಎಕ್ಸ್ಟ್ರಾಮ್ಯೂರಲ್ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್. ಓಕೆ, ಇಂಟ್ರಾಮ್ಯೂರಲ್ ಅಲ್ಲಿ ಪೆಲ್ವಿಯೂರೆಟ್ರಿಕ್ ಜಂಕ್ಷನ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗುತ್ತೆ. ಇಂಟ್ರಾಲುಮಿನಲ್, ಲುಮೆನ್ ಒಳಗಡೆ ಏನು ಕಾಸ್ ಇರ್ಬೋದು, there can be stone or there can be diabetes mellitus which is leading to obstruction. Okay, similarly retroperitoneal fibrosis and retrocaval ureter are extramural causes. Ureterocele, ureteric stricture, urothelial tumor, all these are intramural causes. Intraluminal bandu papillary slough, ureteric stricture. Again, ureteric stricture can be intramural or it can be intraluminal based on what is causing the ureteric stricture. Okay, other than that, analgesic nephropathy, again this will damage the lumen. And then sickle cell anemia, all these are intraluminal causes, and these are unilateral causes. Bilateral causes will be usually systemic and congenital. Okay, congenital causes for bilateral nephrosis include posterior urethral valve and urethral atresia. Urethral atresia agidre, again there is no out passage part. So bladder orgu ella chanagide, but bladder inda ಆಚೆಗೆ ಹೋಗ್ತಾ ಇಲ್ಲ. So everything from the bladder will get reflexed back because urethra is absent, and because of that reason both the kidneys will be enlarged. So congenital urethral atresia will lead to bilateral hydronephrosis. Acquired bladder neck stenosis. So bladder inda ಕೆಳಗೆ ಹೋಗ್ತಾ ಇಲ್ಲ. BPH, again it is surrounding the urethra. So urethra BPH ಆದಾಗ ಏನಾಗುತ್ತೆ, BPH it is nothing but hyperplasia. So because of that there will be obstruction of the urethra. Urethra obstruction ಆಯ್ತಂದ್ರೆ everything will be back flowing. So because of that again there will be bilateral hydronephrosis. Similarly, carcinoma of the prostate, BPH or carcinoma of the prostate, same will be the pathology. There will be obstruction will lead to backflow will lead to hydronephrosis. Similarly, urethral stricture. So urethra, not ureter, because once there are 2 ureters but only one urethra. So urethra is a common passage. If this gets obstructed, everything will backflow similarly, symmetrically, and that will lead to bilateral hydronephrosis. Yeah. So what will be the clinical features in case of unilateral hydronephrosis? There will be mild to dull aching pain, acute ureteric colic irutte, intermittent hydronephrosis, that is called as Dietl's criteria. Okay, patient will present with severe pain in the flank and palpable swelling, which will usually disappear after passage of large volume of urine, because kidney is getting enlarged. Because of that stretch of the renal capsule they are experiencing pain. Once they pass the large volume of urine, kidney will relax and there will be relaxation of renal capsule also. Because of that reason again there will be no pain. Okay, this is seen in case of unilateral hydronephrosis. Bilateral alli enagutte, symptoms of bladder outlet obstruction like lower abdominal pain barbodu, vomiting ಆಯ್ತಾ. ಸೊ ಈ ಥರದ್ದೆಲ್ಲ ಫೀಚರ್ಸ್. renal symptoms will occur after renal failure. ಸೊ ನಾವು ಈ ಬ್ಲ್ಯಾಡರ್ ಔಟ್ಲೆಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಏನು ಟ್ರೀಟೇ ಮಾಡಿಲ್ಲ ಅಂದಾಗ ಇಟ್ ವಿಲ್ ಗೋ ಫಾರ್ ರೀನಲ್ ಫೇಲ್ಯೂರ್. ಆ್ಯಂಡ್ ರೀನಲ್ ಫೇಲ್ಯೂರ್ ಆದಮೇಲೆ ರೀನಲ್ ಫೇಲ್ಯೂರ್ದು ಸಿಮ್ಟಮ್ಸ್ ಬರೋಕ್ಕೆ ಶುರು ಆಗುತ್ತೆ, ಲೈಕ್ ಯುರೇಮಿಯಾ, ಟಾಕ್ಸಿಸಿಟಿ, ಅಂದರೆ ಪೇಷಂಟ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಗೆಟಿಂಗ್ ಡಿಸೋರಿಯೆಂಟೆಡ್, ಕೋಮಾವರೆಗೂ ಬೇಕಾದ್ರೂ ಹೋಗ್ಬೋದು. ಹೆಪಾಟಿಕ್ ಹೆಪಟೋರಿನಲ್ ಸಿಂಡ್ರೋಮ್ ಈ ಥರನೆಲ್ಲ ಆಗೋಕ್ಕೆ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ. ಓಕೆ, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಏನು ಮಾಡ್ತೀವಿ ಇನ್ ಕೇಸ್ ಆಫ್ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್? ಅಗೇನ್ ಫ್ಲೂಯಿಡ್ ಇಸ್ ಗೆಟಿಂಗ್ ಅಕ್ಯುಮುಲೇಟೆಡ್, USG. ಆ್ಯಂಡ್ investigation of choice for diabetic for hydronephrosis is DTPA, that is special radionucleotide scan, which is used to study perfusion, renal perfusion. Okay, so how will we manage this? If less than 10% kidney function is there, then it is an indication for nephrectomy. If more than that is there, then treat the underlying cause. ಅಂಡರ್ಲೈನ್ ಕಾಸು ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಲ್ಲ, ಯುರೆಟ್ರಿಕ್ ಸ್ಟ್ರಿಕ್ಚರ್ ಇದ್ದರೆ ಸ್ಟ್ರಿಕ್ಟ್ ಡೈಲೈಟ್ ಮಾಡೋದು, ಕಂಜನೈಟಲಿ ಆಗಿದೆ ಪಿ ಯು ವಿಗೆ ಏನು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕು ಅದನ್ನು ಮಾಡೋದು, ಬೇರೆ ಯುರೆಥ್ರಲ್ ಅಟ್ರೇಸಿಯಾ ಇದ್ದರೆ ಯುರೆಥ್ರಾಗೆ ಏನಾದರೂ ಅಟ್ರೇಸಿಯಲ್ಲಿ ಟ್ರೀಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಅಗೇನ್ ಬ್ಲ್ಯಾಡರ್ ನೆಕ್ ಸ್ಟಿನೋಸಿಸ್, ಬಿ ಪಿ ಎಚ್ ಇದ್ದರೆ ಟರ್ಪ್ ಮಾಡ್ಬೋದು, ಸಿ ಎ ಪ್ರೋಸ್ಟೇಟ್ ಇದ್ದರೆ ಅಗೇನ್ ಸ್ಟೇಜಿಂಗ್ ಮಾಡಿ ಅದಕ್ಕೆ ತಕ್ಕಂಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡ್ಬೋದು ಈ ಥರ. ಸೊ ಇಫ್ ಲೆಸ್ ದೆನ್ 10% ಆಫ್ ದ ಕಿಡ್ನಿ ಈಸ್ ಫಂಕ್ಷನಿಂಗ್, ದೆನ್ ದೆರ್ ಇಸ್ ನೋ ಅದರ್ ಟ್ರೀಟ್ಮೆಂಟ್ ದೆನ್ ನೆಫ್ರೆಕ್ಟಮಿ. ಸೊ ದಿಸ್ ವಾಸ್ ಆಲ್ ಅಬೌಟ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಆಫ್ ದ kidney and ureter. Okay, we mainly discussed 6 diseases: emphysematous pyelonephritis, xanthogranulomatous pyelonephritis, after that pyonephrosis and perinephric abscess. And this one is in your curriculum, they have mentioned it separately, perinephric abscess. So abscess around the kidney ಅಷ್ಟೇ. This can be hematogenous route ಅಲ್ಲ ಸ್ಪ್ರೆಡ್ ಆಗ್ಬೋದು, ಇಲ್ಲ ಥ್ರೂ ಕಾರ್ಟಿಕಲ್ ಎಕ್ಸ್ಟೆನ್ಷನ್. ಓಕೆ, ಇವೆರಡು ಗೊತ್ತಿರಲಿ ಇದ್ರ ಬಗ್ಗೆ. ಆಫ್ಟರ್ ದಟ್ ವಿ ಡಿಸ್ಕಸ್ಡ್ ಅಬೌಟ್ ಜನೈಟೋ-ಯುರಿನರಿ ಟಿ ಬಿ. ಆಫ್ಟರ್ ದಿಸ್ ವಿ ಡಿಸ್ಕಸ್ಡ್ ಅಬೌಟ್ ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್. ಹೈಡ್ರೋನೆಫ್ರೋಸಿಸ್ಗೆ ಬಂದರೆ ಅಗೇನ್ ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಯೂನಿಲ್ಯಾಟ್ರಲ್ ಆರ್ ಬೈಲ್ಯಾಟ್ರಲ್. ಯೂನಿಲ್ಯಾಟ್ರಲಿ ಕಾಸಸ್ ಬೇರೆ ಬೇರೆ ಇರುತ್ತೆ, ಬೈಲ್ಯಾಟ್ರಲಿ ಕಾಸಸ್ ಬೇರೆ ಬೇರೆ ಇರುತ್ತೆ. ಯೂನಿಲ್ಯಾಟ್ರಲ್ಗೆ ಅಗೇನ್ ಯು ಕ್ಯಾನ್ ಡಿವೈಡ್ ದ ಕಾಸಸ್ ಇಂಟು ಎಕ್ಸ್ಟ್ರಾಲುಮಿನಲ್, intraluminal, extramural, intramural and intraluminal. This congenital and acquired. ಅದಾದಮೇಲೆ ಸಿಂಪ್ಟಮ್ಸ್ ನೋಡಿದ್ವಿ, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಯು ಎಸ್ ಜಿ ಆ್ಯಂಡ್ ಡಿ ಟಿ ಪಿ ಎ ಮೇನ್ಲಿ. ಟ್ರೀಟ್ಮೆಂಟ್ ಬೀಯಿಂಗ್ ಲೆಸ್ ದೆನ್ 10% ಇದ್ದರೆ ನೆಫ್ರೆಕ್ಟಮಿ, ಮೋರ್ ದೆನ್ 10% ಇದ್ದರೆ ಐಡೆಂಟಿಫೈ ದ ಕಾಸ್ ಆ್ಯಂಡ್ ಟ್ರೀಟ್ ಇಟ್. ಓಕೆ, ಸೊ ದಿಸ್ ವಾಸ್ ಅಬೌಟ್ ಇನ್ಫೆಕ್ಷನ್ಸ್ ಆಫ್ ಕಿಡ್ನಿ ಆ್ಯಂಡ್ ಯುರೇಟರ್.